Thank you for joining us today. My name is Rebecca Kiesling, and I am the Managing Director at Benjamin Rush Institute. If you have not joined us for a virtual event, one of our events at the virtual event series before, to give you a little bit of background information, Benjamin Rush Institute is a national organization dedicated to the education of medical students across the country and at our international chapters on free enterprise healthcare alternatives that they're just not receiving in medical school. Very excited about the virtual event series, which we started in response to the COVID-19 pandemic when medical schools across the country and across the world shut down. We wanted to continue that education, so we started these webinars asking our network, our contacts, if they would continue the education with us, and we've had such a great response to them. We decided to continue even though schools are finally opening up. It's been great because we've gotten to share outside of just with medical students, our supporters, physicians who are advocates, as well as those who are thinking about becoming advocates for their profession. Now with probably around 30 under our belts, we appreciate everyone that has sat with us to talk about different avenues of free enterprise healthcare and all of the different varieties that can take. As this continues, I'm very excited to talk to our guest today. I got the chance to meet him at a conference that we were at, the Free to Care conference in Texas last year. And his enthusiasm for change in healthcare was catchy. It was a pleasure to speak to him, because to have a physician who wants to create change and is willing to talk about that and to do something about that is what we need more of. And so I am thrilled to get a chance to speak to him, and I guarantee that everyone out there is going to hear his enthusiasm. Dr. Mitch, Mitchell Lee, is a board certified emergency physician who believes that our healthcare system requires a grassroots overhaul. Music to my ears. Patients and clinicians are routinely taken advantage of by a broken system. For those in need of vital healthcare services, Dr. Mitch believes in a first do no financial harm approach with transparency at the core. No surprise bills. Dr. Lee is founder of the public benefit company Take Medicine Back and currently serves as the chief medical officer of the American Academy of Emergency Medicine, Locum Group. Dr. Lee completed his residency training in Detroit, Michigan, where he served as a medical director for the Wayne County Special Response Team. He is also the founder of Thrive Direct Care, predicated on the direct primary care model and providing transparent access to an emergency physician without the need for insurance. Again, I guarantee that what you're going to experience today is a lot of enthusiasm, but also you're going to hear a lot of information about emergency medicine and residencies and grassroots that you might not have heard before. We are streaming live on Facebook. We are streaming it in 2 chapters and also here on Zoom. So I hope that you will ask questions in all of those different variety. Dr. Mitch is going to speak, and then I'm going to take in all of those questions. And then we're going to ask them, trying to keep this right at about an hour. Thank you all for joining us, and I'm going to turn it over to Dr. Mitchell Lee.
All right, thank you, Rebecca. Thank you for that introduction, and it was a pleasure meeting you as well. And I love just mixing up with different parts of the healthcare advocates in this space, because it's sorely needed. And as mentioned, let's see, I'm going to share my screen here if I can. Okay. Okay, I think that should be up there. As mentioned before, it's that we do need a grassroots overhaul is my perspective, but I'm 35. I'm 5 years out of residency. And if we look back to, 30, 40 years of what we've been trying to do as far as an overhaul of the healthcare system, we haven't really moved the needle much, even if you consider the Affordable Care Act. That was, depending on who you are, you might say that was a step from the right direction, or it was the most disastrous thing that happened to American healthcare. I say it barely changed anything. It really reinforced the system that we had previously. And I think we've really reached what amounts to like a stalemate from a congressional and legislative standpoint in terms of fixing medicine. So my perspective has changed since I was a health policy major in college, through working through organized medicine and then through medical school and residency, to learning a few perspectives, especially with direct care, that I think we mostly need to sort of step around the system. It's a broken system, and just sort of beating up against it and ramming up against it is not going to be as effective. So that colors a lot of my perspective. So I am a board certified emergency physician. I do have a direct care private practice that I do probably more as a passion project, because I still work in the emergency department. But I really feel like it brings us back to the root of medicine. But this gives me perspective on two different extremes. They're both general fields of medicine, but two different extremes in terms of the acuity, which also colors my perspective on transparency and free market type medicine. So I'm going to start this out with hopefully what is maybe a little bit of a provocative question, and maybe just keep this in the back of your mind. What is extremism, and what do QAnon and Antifa have in common? And what the heck does this have to do with medicine? So we'll just keep that in the back of your mind as we move forward. My background after medical school, I went to medical school at UMass Medical School in Massachusetts. I went to residency at St. John Hospital in Detroit for emergency medicine. Now, while I was there, the emergency medicine group that staffed the ER was purchased by Team Health. I say purchased, it was sold by the two owners, 130 physician group. It was a private group. The physicians there were told that they were partners. They were called partners, but only two of the physicians actually had any equity in the company. So, and I don't have exact numbers on this. I think it's more hearsay, but it's in the same range, that the two owners of the group sold it for around like $40 million each. So they got a little golden parachute, and the rest of the physicians that were there ended up being employees of Team Health. I wasn't paying that much attention to this at the time. I was still excited to do thoracotomies and learn emergency medicine, and I kind of toned a lot of this out. But while I was there, the next year or a couple of years later, Team Health was acquired by Blackstone for $6.1 billion. Team Health is now one of the largest staffing companies in the country, along with Envision and US Acute Care Solutions. They staff mostly emergency medicine, but also hospitalists and anesthesiologists, perhaps some other services as well. So this is a private equity firm, and we're going to learn a little bit more about private equity coming up. But all this was happening in the background, which sort of colored my perspective here. Now, during this changeover, a lot of our educational emphasis kind of changed more toward how do we, quote unquote, produce more. And we're talking about patients, right? So how do we produce more RVUs by billing more, by documenting more, by moving them faster? It became more of a focus on this. Our lectures, instead of, learning about emergency medicine, of course, we still had that, but they became interrupted by the medical director, who honestly looked scared for his job and started pleading with us to improve metrics. So metrics of throughput, left without being seen. Like, could we, waiting room in Detroit, we had, often 4 to 8 hour waits, which is not uncommon in urban areas. And of course, people would leave during that time. So could we actually see them, or could we just kind of put an eye on them and rubber stamp the chart as if a doctor actually saw the patient or a non-physician? Patient satisfaction, which you may or may not be aware, actually in a representative sample study across the U.S., correlated with higher mortality rates. So you actually had a higher likelihood of dying if you had a higher more satisfied patient. Patient satisfaction scores are actually, Press Ganey is the most common one, is actually owned by private equity itself. Are we measuring meaningful metrics is really the question. Most of these metrics translate into better pay for the company employing us, but not necessarily better quality. So a focus became on that, and we actually started believing, or we created a new unofficial mascot, and we felt like rats on a wheel. One of my coworkers, residency colleagues, came up with this, and we discussed it in WhatsApp, that we felt like rats on a wheel. And then the image on the right there, a weightlifting rat, became our sort of unofficial mascot, because as much as we just felt like tools to generate RVUs for our attendings, which of course was part of the picture, but we were also generating RVUs for a big private equity owned company above us. We kept our morale up by saying, well, but we are the strongest rats. So that was our unofficial mascot. And it kind of is telling as to the direction that healthcare has become. We're kind of more like widgets. So was that unique? Well, there has been a lot of consolidation in emergency medicine. The classic model is that a group of 5, 10, 15 doctors in the local community own their group. Maybe they all have an ownership stake or a partnership path, and then they get to make decisions with the group. Now, you still have to negotiate with the hospital, and hospitals have been consolidating as well and acting in more corporate mindsets. But when you had a nice independent hospital in the community and you had a group of physicians, they could be contracted as physician owners, which is actually the legal way in most states, because many states have corporate practice of medicine laws that forbids corporations from owning physicians and practicing medicine. So right now, an estimated 40% of emergency medicine ownership is by private equity. If you go to an ER, there's a good chance that if you see a doctor, about 50% chance the doctor, if you see one at all, is owned by a private equity firm. So this is a growing problem. Emergency medicine, this is a very recent, I think, Medscape article, shows a burnout of 60%. We're topping it. We used to think that, well, emergency medicine was just burned out because we weren't really prepared for it. It was family physicians that were going in and weren't prepared for emergency medicine. And so we're going to change that. But as you see, we're still topping that. And we are, I would argue, the most corporatized specialty. There's certainly problems in other specialties. Family medicine has been, and internal medicine, primary care has been, harmed by essentially hospital buyouts and the insurance-based system. But emergency medicine, I think, is a pioneer in corporatization, but it is spreading to other specialties rapidly. So we'll back out for a second. That's a bit of what drove me here, as well as starting out with, upwards of $300,000 of educational debt, and just starting on a personal finance journey to figure out how I could not live paycheck to paycheck and make the mistakes that physicians are infamous for with a lack of personal finance education. So we all like transparency. Certainly the chapters of BRI, I think, are very, very big on transparency. And I love that. And that's what got me really excited about direct primary care. So when I was listening to personal finance podcasts and doing journal reviews, basically, I called it like Personal Finance Journal Club, I came across Josh Umber, and many of you might know, on a podcast of Dr. Money Matters. And I learned about essentially transparent pricing. As you also may know, there's the federal rule for hospitals to be transparent on their prices and put up a machine readable file of prices. However, these are being broadly not followed, as well as if they are followed, they're sometimes actually buried in the website purposefully. If you've heard of SEO, like search engine optimization, so that a search engine will find your site, they're doing sort of like reverse SEO so that you actually can't find the transparency, their transparent lists. And then, of course, it's really a data dump. So for the average person to take a look and make it a real, like, usable something, an actual usable interface is very far off. Finally, the there's actually concern by the Federal Trade Commission that this level of transparency might not be usable to the average person, but it might be very usable to insurance companies that could then mine the data and use it to actually increase prices. So there's some issues with that, but this is what actually got me into transparency. It was the simplicity of this. These are my prices that I have right now, which will change. Hopefully it'll be a little bit cheaper. This is my direct care practice. And we being myself and an RN, actually patient advocate, are working on a guide called How to Hack Your Healthcare, which is going to be more patient centered and focused. Basically, whatever situation you are in, here's how to get the best situation for you and your family, whether you're uninsured, a private, an independent contractor, a business owner, or of any version of that. So what really blew my mind was when I heard that labs, like your common labs, are going to be like $3-4. And this, physicians have no clue about generally, unless you reach outside of medical school. So we have no idea what we're doing when we're ordering in the emergency department. When you talk about resource management, we don't want, those are fake numbers because they're filtered through insurance companies. They are often called charge master bills, which are just made up numbers, kind of like the MSRP on a car, but even more marked up than that. You're not actually supposed to pay them, but we don't have real meaningful numbers. So in my practice, if I were to order your annual labs, you're talking about under $30 or so for that without insurance. And the truth is, what I have realized for more than one reason is that insurance mostly inflates the cost of healthcare. And we could talk about the medical loss ratio and how that was also baked into the Affordable Care Act, which created a perverse incentive for insurance companies to actually increase the cost of healthcare so long as they can pass that cost on to consumers in the form of higher premiums. So very broken there. This really blew my mind and got me down the path of learning about direct care. And as I mentioned, I have a small practice that I love. I'm still practicing emergency medicine, so I have sort of a slow growth, low overhead direction in that, but it's extremely rewarding. We've all, or probably most of you, heard of the Surgical Center of Oklahoma. You can go ahead and just look up a surgery and check out the price. And of course, they might be expensive, but but not as expensive as a hospital. It's transparent. You can do some comparison shopping. There's another one of these that opened up in Indiana recently, and I actually sent one of my patients there when I was in Chicago for a stone removal. She had a 10-12 millimeter stone that somehow was obstructing but not painful, and so it wasn't a complete emergency, and we were able to do that and find a great price for her. She had a great experience. So that was my personal experience, at least getting one of my patients there, and she was uninsured, completely uninsured, and had no had no health share. And so she was able to save, and raise some money for that. And then she wasn't in massive debt, unlike had she probably gone to a hospital and then got collections going after her. So that's great. But now we look at emergency medicine. That's what I'm board certified in. This is where I trained, and it's kind of two extremes, right? We mentioned that patient had a kidney stone that wasn't causing pain, but if anyone here has seen kidney stones, in a ureter or obstructing, you don't wait a month to take care of those. They are immensely painful, probably, up there with childbirth, or even worse if you ask some women who have had both. So this is one thing that would become an emergency. Of course, we all sort of think about, and this is always the question that comes up with direct primary care. Well, what about emergencies? What when I need to see a specialist? What about expensive things? What about cancer? And so two extremes of this. One, transparency does work in stuff that you can take your time for. It works sort of. There's not really good competition where I am in Western North Carolina, where HCA, or the Hospital Corporation of America, has a virtual monopoly, along with another private equity owned hospital, LifePoint. The competition doesn't really work well for services. But in theory, we could get a free market in elective type procedures and surgeries, and you can use a health share. However, what about when you have a true emergency? You don't have time to shop around, and you're also very much limited by geography, because you have to go to the closest hospital, and you may be at the whims of the ambulance or air ambulance that brings you to that hospital. So transparency in emergency medicine is a different beast. It doesn't work quite as well. And when you go to the ER, there's a law called EMTALA that many of you may be aware of, which is the Emergency Medicine Treatment and Labor Act. Now, it's considered an unfunded mandate by the American College of Emergency Physicians, and they're correct in that. It's essentially America's way of having universal health care without actually having universal health care. It means that everybody in America can go to a hospital and is legally entitled to a medical screening exam to evaluate for an emergency, as well as treatment and stabilization of that emergency and definitive transfer or definitive treatment, which means they have to take care of the patient if they have that ability. So if they have a cath lab and a cardiologist, they have to do the correct like STEMI treatment and stent at that hospital so that they don't dump patients without insurance to, the county hospital 20 miles away or something. So if you move a patient and you have the resources to take care of them from an emergency perspective, then it's considered an EMTALA violation, and it does come with hefty fines that actually go right onto the physician themselves and the hospital. So the fines there and the regulatory burden that would come down on after them is actually respected, unlike the transparency law that's like that $300 a day, which is pocket change. So we have this, but this now sets up this dynamic where patients can come to the ER and without insurance or with insurance, they can be seen, but they don't know what the bill is going to be up front. Of course, even if there was real transparency, we don't know what we'd have to order exactly. So it's hard to come up with a real transparent process. However, the patient signs a release to a consent to treat, and usually buried in there is also consent to pay whatever the ER or hospital charges them. Now, there is a legal term for this, and I forget the name of it, but essentially there isn't much legal precedent, or there is legal precedent that signing to pay a made up number that they haven't presented you with doesn't give them the license or the right to charge you anything. But hospitals tend to use this. Hospitals and private equity owned emergency medicine groups tend to use it in that direction, and they'll charge an outsized price that isn't actually reasonable fair market value because there's no market here. So we'll take a quick step back here. That's the context. Transparency works in some sections. And if you have a health share, then theoretically they can help negotiate the appropriate price after the service was rendered. And insurance was supposed to theoretically do that, but as we saw, there are some issues. And then there's something called surprise out-of-network billing that we'll get to. So I wanted to switch gears though briefly and talk about what is private equity. When I say private equity, it's a horribly named term. And that's partly by design, because this is actually a rebranding of the leveraged buyout industry that was mostly from the 80s. And we'll see a lot of this stuff began in the 80s. Like me, I was born in the 80s, but then also this version of corporate leverage buyouts was also put into high gear around there. So private equity is not referring to just private ownership. So when we say that we think private equity is bad, a lot of people hear, wait a minute, you're talking about communism. You're saying that nothing should be private, and that's not at all it. This was a headline from The Onion. Protesters criticized for looting businesses without forming private equity firm first. And I think it sums it up probably the best I could if we're going to minimize time discussing it. Private equity is a form of investment or purchasing, private investment purchasing, that minimizes the risk or almost eliminates the risk to the firm and what we call general partners buying out a company. Most of the time, these are mature companies that couldn't really benefit much from being bought out in the first place. And if the company succeeds, then the private equity owners, or what we would call general partners, are able to get outsized returns. If the company fails, then that failure, that bankruptcy falls on society, it falls on the workers, and it falls on the company itself. And that's because with these leveraged buyouts, the firms actually take out huge loans in order to increase the capital of the company so they can expand, mostly expand, and quote unquote, possibly do improvements. Now, that debt is actually placed on the company itself. So it's usually high interest debt. And if the company fails and defaults on that debt, then that doesn't fall on the private equity owners. They're completely shielded from that. And so no matter what happens, they actually make money from primarily assets under management or just a percentage of the money from other outside investors, which tend to be like pension funds. It's about the third of the money of outside investors that invest in private equity projects. So in other words, pension funds and workers are getting kind of ripped off because they're not getting the outsized returns that the investors are, and they're getting a lot of their investments eaten away by assets under management. As an aside there, that's also how a lot of personal finance advisors or personal financial advisors work, is they have hidden fees that take a big percentage of your assets under management when they're, saying they're going to do investing for you. And a lot of them like to be predators of medical students and develop a nice relationship until you start having a steady income, and then they steadily leech off of that. So fair warning from a financial advisor perspective, that's what's happening on a large scale here. So there are many examples of this in society. Toys R Us and Art Band Furniture, Nine West, and Toys R Us and I'm totally blanking on the name of it, but lots of retail has been a big one. PetSmart, Petco, all of these have been bought out by private equity. And what we see for the most part is that we don't see improvement in the processes, which is what they say they would do to increase profit, but rather just cutting labor. So understaffing, that kind of a thing. So this is the timeline for private equity. Essentially, you talk about the formation, you find something to invest in, and then this labels it harvesting. And for the most part, private equity funds want to dump their investments after 7 years back onto the public market or to another private equity firm. And the criticism here is that they're using businesses as piggy banks and just extracting or harvesting from them. Sometimes they go on for a longer time period, and there's this extension period because they can't find a good buyer or something along those lines. So this piggybacks or dovetails, I should say, with surprise medical billing. You may have heard of surprise medical billing, and physicians have been sort of blamed for it. Insurance has been blamed for it. And what I would like to say is that a lot of the involvement of private equity groups has been hidden and in the background here. So we talk about surprise medical bills, and what it really means is when a physician or physician group goes out of network with an insurance company. And the idea here is that an insurance company might be offering the physician group a paltry amount. And if they have a monopoly on the area, then they might not be offering a very good amount for the physicians to go in network. So particularly in emergency medicine or emergency surgery or anesthesia, they can go out of network and the insurance company will still have to pay. So they might present a bill to an insurance company that's marked up 8 to 10 times what Medicare might reimburse. Now, Medicare arguably is not enough to keep a hospital door open. So the general feeling is that 2 to 4 times Medicare is probably more fair. Of course, nobody likes to benchmark to Medicare because the government sets that rate. But for sake of reference, 2 to 3.5 times is considered pretty robust for a reimbursement. And a lot of private insurance is reimbursed in that range. So what instead is happening is these hospitals and physician groups present a 10 times Medicare type bill to the insurance company. The insurance company pays a part of it, and the balance, the difference, goes to the patient, even if they have insurance. So that can blow right past their out of network, their deductible, or their max out of pocket. So currently there is a No Surprises Act. I won't go super in depth there, except to say that a lot of physician groups are upset with how it was implemented because the implementation favored the insurers in terms of how much is going to get paid. I'll leave it there right now, but I'd like to throw a little attention to the number 4 here that says doctors spend more or send more surprise bills than do hospitals. And I would say our names are being kind of dragged through the mud, even though we as physicians in emergency departments, in most cases, have no access to what's billed or collected in our names. And if we asked, we're fired. So I don't love that our names as physicians are sort of being put out there as being greedy and harming society. The ProPublica article goes into detail about this, how rich investors, not doctors, profit from marking up ER bills. This goes back to private equity. It goes back to contract management groups owned by lay entities, and how we don't have any transparency here. If you might have heard some things about how insurance companies are the reason behind surprise bills, but what you hear less about is the private equity firms that actually own the physician groups. So physicians get blamed for it, but in the background are private equity companies that aren't actually paying us our due worth, while running ads actually from a group called Doctor Patient Unity, again, dragging our names through the mud, saying that it's all insurance companies profiting from patients' pain through rate setting, which is actually really twistedly ironic, because it's the private equity companies that are profiting off of patients' pain at actually a much higher degree than the insurance companies are. So now we get to labor exploitation, and we don't like to think of this as physicians. We used to own our practices. We know that across the specialties, this has been steadily going down and rapidly going down, not just in emergency medicine. So once we're employees, especially when employees of a large corporate conglomerate with extreme pressures to turn profits in a short period of time, we're enter the same kind of labor exploitation as being in a meatpacking house or, Amazon workers. This is a little bit fuzzy, but this is a slide from Envision, which is owned by KKR, the private equity company KKR. This is from Kirk Jensen, the chief innovation officer at Envision, and this was given at the American College of Emergency Physicians at a ED, emergency department directors class or course that was sponsored by Team Health. So a lot of private equity there, a lot of private equity and corporations in our specialty societies. This was teaching medical directors how to replace you with whatever's cheaper. So this is a medical director or innovation officer, and you'll see that the innovation in private equity companies isn't about how do we provide better care, it's how do we make more profits for the investors, how do we service our debt. So we're going to employ the least expensive resource to accomplish the mission. Now, with shareholder supremacy or primacy, we know that the mission isn't quality patient care, it's service the debt, make money for investors, make money for the GPs. So that means that APPs, being non-physician practitioners, can see up to 85% or 35% of cases seen independently by APP. So they're actually advocating for, independent, non-oversight work by non-physicians. Just to put this in perspective, emergency medicine is 30 something years or a little older than that. 60s is when emergency medicine was started to be born. And that was out of a recognition that we probably need some specialties that focus on picking out the subtle emergencies. Like, for example, even family practitioners and internists, which would be the next best specialty, have the broadest base, we recognize wasn't quite enough for high quality emergency care. So this is going back and saying, well, why don't we just put non-physicians who haven't even gone through, medical school or residency, and then family practitioners and internists, so long as we can pay them less, or if we can utilize residents and SOPs, which is standard operating procedures, treatment protocols. This is cookbook medicine, right? So this is what the vision of a private equity owned contract management group is. We'll push this one further ahead. Envision was extremely reliant on out-of-network surprise billing. So now that they don't have that, we're seeing a lot of potential for bankruptcy and austerity measures that are really going to cut more down on the staffing side. This is APP, American Physician Partners, which is, I believe, backed by Apollo, which is another private equity company. This was a pitch to investors to raise more capital when they realized that the No Surprises Act was going to create the fact that they couldn't just overcharge patients anymore. You can't exploit patients. Now, what are we going to do? We're going to change how we pay physicians to make it productivity, which you can't control really, because if you're in an ER, you don't know how busy it's going to be. So they're placing that risk on the physician. Staffing change mix means replace physicians with MLPs, mid-level providers. Staffing reduction, so reduce overall, swap out some MDs with non-physicians when possible, and then elimination of premium pay. That's a little bit of a euphemism. It says elimination of coverage bonuses or overtime. So in other words, if you stay 3 hours past your shift to help take care of a dying patient or doing all of the documentation that actually allows them to charge, they won't pay for that now, which is fairly common. In emergency medicine is unique. We know there's a physician shortage overall, but in emergency medicine, there's actually projected oversupply. This has been largely what we believe to be the result of increasing numbers of corporate residency programs. So Envision, Team Health, in conjunction with Hospital Corporation of America, have opened up essentially the most programs in the country for emergency medicine. And we believe this is essentially creating a labor monopsony, which means that there's only one buyer of labor in the area. So if you overproduce emergency physicians, you replace them with nurse practitioners, then you can drive the salaries down into the ground. And this is kind of illustrated here clearly that these companies want to take advantage of that to keep rates low. So while we're dealing, with the pandemic, this was 2021. Young ER doctors risked their lives on the pandemic's front lines, but they struggled to find jobs. We know that they were cutting hours. Initially, ER volumes did decrease, but the idea is these companies just really cut hours aggressively while they're getting bailouts from the CARE Act. There's an awful lot of corporate welfare going on that is how I would frame it. So as I mentioned, there's a lot of replacement of an intent to replace physicians with non-physician practitioners. And what you'll see in the future, although we believe they do have a role, is that these companies make their profits by a deceptive notional supervision arrangement. Of course, there's a push for independent practice in many states for nurse practitioners. There's also a push for reimbursement parity, which means that an NP feels like they're doing the same job as a doctor, so they should get reimbursed the same amount from the insurance company. Of course, if they don't own the practice, then it's the practice or the corporation that gets reimbursed the same amount for a practitioner who they can pay a third of the amount as a physician. So there's this economic incentive to treat them as advanced billing widgets. If we're billing widgets, then a billing widget you can pay a third of the amount for is pretty good from a business standpoint. So we are opposed to notional supervision, which is the idea that we're rubber stamping charts of non-physician practitioners when we didn't actually get to supervise them. We may get a chart 3 or 4 days later. If something bad happened, the patient would already be dead by the time we have to rubber stamp the chart and then accept all of that liability. And that also allows the company to bill as if they were seeing a physician. And so we're ripping off society that way and essentially abetting fraud. So this is a recent article. Doctor fired from ER warns about the effect of for-profit firms on U.S. healthcare. He talked about understaffing. This is happening over and over again. He actually won this lawsuit against MCare, which is owned by Envision. And this was several years ago, but he actually just spoke out about this. It was covered by Gretchen Morgenstein and on NBC News. There's more examples of there. I kept them out so we would have time. I just wanted to call attention to what was also brought in shown in this lawsuit and during discovery is that there's a Dr. Gregory Byrne, an emergency medicine practitioner, who was the paper owner of 300 emergency medicine practices. And the entire structure of private equity and these contract management groups is actually built on deception. In most states, they are violating corporate practice of medicine laws, which state that basically a big profit-seeking entity shouldn't be owning the practice and that a doctor should be. Now, these are not being enforced anywhere, and the way that these companies have been getting around it is by taking a physician who will sell out their license, or not even license. I don't think they have to have a license. They just have to have an MD or a DO, and then put their name on paper. And this is another form of corporate welfare where they do nothing except take some kind of salary for borrowing, we'll say, selling out their license on paper to make it appear that they own it, when in fact they are stripped of all shareholder rights. So they have no control of the company. It's just a pass-through shell corporation. So this is going on throughout the country, and it was actually noted about 30 years ago this was starting to happen. Remember, I mentioned all this bullshit, excuse me, my French, started in the 80s. This book was written by Dr. James Keeney in 1992 as a recognition of the corporate abuses that were beginning in emergency medicine. And it actually resulted in the founding of a new emergency medicine trade group, and that's the American Academy of Emergency Medicine. The American College of Emergency Physicians was the original group, and it was broadly recognized that the fox had entered the hen house, and that pioneers of this corporate model were actually in the leadership of ACEP. And this is still true to this day, perhaps worse. But the rate of emergency medicine started a bit of a movement in emergency medicine that we're largely continuing today, and we continue to work closely with the American Academy of Emergency Medicine. So this is actually a study done by the American College of Emergency Physicians, the one I mentioned that had a lot of foxes in the hen house. That doesn't mean that physicians there are all bad. It's the largest organization and it's the most well known. And so there are good doctors there doing good work, but they're largely suppressed by the leadership. So this slide came out from the workforce task force at the American College. It was sort of leaked out in a document. You will not see this shared by the American College of Emergency Physicians, except in the speech by the president, where she drew into question whether this was representative, because some of the participants hadn't actually worked in a private equity group, so maybe these are invalid, right? So mostly there's a push from the American College to draw a question as to whether corporatization is actually bad. We have no idea. We have to study it. Well, let's study it for, to me, this is akin to studying a patient who's in ventricular tachycardia and unstable and send out labs that take 4 or 5 days. And by the time you get them back, the patient's going to be dead. And that's sort of where I feel we are at the stage of corporatization in medicine. It's been going on for 30 years. I think of it as uncontrolled corporate diabetes, and now we're getting STEMIs and end-stage renal disease, and we're seeing all of the things that are turning into emergencies. So it's time to act. So we'll go back a little bit to sort of the initial question. QAnon, I've got a physician that I work with who sends me all kinds of QAnon stuff. It obviously doesn't, is not just to non-educated populace. And of course we have sort of Antifa, whatever you believe, if that's even a real thing, or the disorganized movement. But what I would argue is that all of these are looking at inequities. And I didn't say inequalities, because I think inequalities are appropriate, but inequities is really what we're talking about, of the sense of what is just or what is fair. I think a lot of people, including sort of the old white male who feels that they're being pushed to the side, feels that there's inequities. And this is where we get we're prone to conspiracy theories. We talk about George Soros. Well, George Soros is a billionaire. And I guess he's on the left side of the spectrum, but people don't trust billionaires. I don't think anybody trusts billionaires, essentially. And this is an emergency physician, Dr. Ming Lin, who was actually fired after speaking out about unsafe practices at his hospital, because these groups like Team Health and Envision will bypass due process rights, which means that if you are raising a patient care concern, they can take you off the schedule with no recourse. He's suing, he has a recourse, but you have to take that kind of a step. He's suing back by the ACLU. I will just say this is from his presentation at our Take EM Back summit last year. Corporate medicine versus totalitarian government, is there a difference? He felt, and he's from Taiwan, he felt like the muzzling that was happening to the Chinese was just the same as the muzzling that was happening to him at the corporation. He got a threatening letter that said he better take down his social media posts, which is what essentially the Chinese government did when the COVID-19 pandemic began. And I think that we end up on opposite political ideologies, when in fact we're all actually just recognizing that there is corruption and inequities and 1984 type stuff. We're just maybe not necessarily blaming the right place. So I'll come back to that last one. What I would recommend is that if you check something out, Peter Goodman is the author of Davos Man, How Billionaires Devour the World. I did speak with him. He talks about Blackstone and Team Health and how it's been harming the healthcare system. And it sort of explains the mindset of the billionaires. George Soros is one billionaire, but for whatever reason, QAnon is focused on him as opposed to like all the other billionaires that are in existence and sort of extracting from society, living off of corporate welfare as opposed to producing. So I think this is a much more balanced take on it and sheds a lot of light. And so what are we doing about it? Essentially, I think First of all, for any physicians or medical students here, I think you can take a look into whether or not you want to go into a specialty, even in primary care, where you can open up your own practice. You are an entrepreneur at that point, but you have to look your patients in the eyes, and you took an oath, which is a little bit of a protective measure from sending them a out-of-network bill and then suing them for, that doesn't really, hopefully that doesn't sit right to you as a physician. So you can pursue a career where you're going to pioneer transparency and help out the direct primary care networks. And you can also, when direct care and that stuff doesn't really work, we're going to advocacy and join us in some of that, where we're actually are appealing to the Federal Trade Commission, which we may not trust government agencies, but what are you going to look to save you? You can go ahead and try corporations, but they seem to not be on our side. The FTC, we've done a bit of research on and is actually well positioned right now, but potentially do something. There is a call to action because they are actually requesting feedback on mergers and how they've affected the general public. So we have a campaign to get physicians, future physicians, nurses to say, hey, how did that hospital merger affect you? How did the merger of your small democratic group where you were a physician owner and now you're an employee of a private equity company, how did that affect you and your ability to care for patients? We already actually got some outside success here, and a headline that doctors worry over private equity deals dominate merger comments. This wasn't even expected. We have an extra month than we thought to drive these comments. I've actually been invited to speak at the FTC's listening session. So it's a live video recorded session that'll be available to the public that's asking about mergers in healthcare. Again, I don't know how this group feels about government intervention, but what I would say is that if you do believe in free market and actual competition, then monopolies prevent that. And that's what this is discussing, is creating a level playing field for healthy competition. I will also just share with you that we are implementing this now. So if you want to figure out, as a physician, as a resident, or as a medical student going into residency, hey, what does that reputation of that that group have? Are they private equity owned? Because it's very hard to tell. Then we're now starting a employer review section. It's just getting started. It's been designed by a colleague of mine who's very astute with lots of math, we'll say, and programming. So it's quite sophisticated, and we're excited to get that going. Otherwise, feel free to get in touch with me and join our Facebook group, Take Medicine Back on Facebook. Let me know that you heard it here, so I know where you came from. And then we're on Twitter as well, and that's my email. And I will open that up. I probably took a little longer than I meant to, but we do have some time for comments. And I see one comment in there, but I'll let Rebecca moderate. Thanks.
No, that was great. Just to piggyback up off of what Dr. Mitch said, if you are interested, students, if you are interested in commenting on the mergers, we have been a part of commenting. We have put it out to our students in the past to comment on different periods, including hospital transparency, where we were, a number of our students were integral in pushing that out to students as future physicians. So please go to Take Medicine Back to see how to put your own comments in. It's a great way to advocate for your profession if that is something that you are interested in doing. So I want to, definitely open, it is something that you can start to do now, is to comment on things that are moving through the FTC and other places that mean something to you and to your profession. So go to Take Medicine Back and see what that looks like. We do have a number of questions. You got to a lot of them. And I want to prioritize some of them because I think they're very important. I see Mrs. Paul on here. One of our students, a longtime student leader, was recently married, and I like calling her out. So a number of things. First, you notice the question here on Zoom on surprise billing. There is a lot being done on, and something to note on surprise billing is it's not always what, and you talked about this, in terms of what the Surprise Billing Act is, and it actually is, which is emergency rooms and how that's being affected. And I think what a lot of people don't understand is that's what it really is. So as it's moving through as it has been enacted, and in its interesting form, yeah, kind of, that's what it really is. Can you talk about, so the question was, what can we do about it? Can you talk about what you know about the new, what was actually passed?
Yeah, and there's also you'll see there's a lot of debate and upset from how it was implemented among physician groups, and I would argue that because basically physicians feel like they're not going to get paid enough, and I'll make that very broad statement because the act essentially deferred to arbitration, and the idea is just where you're going to start negotiations, right? Are you going to start negotiations with the 10 times Medicare bill that the company was sending out, or are you going to start mediating at the median in-network insurance rate? And so essentially that was chosen. It's being litigated. American College of Emergency Physicians is litigating how that was implemented. What the physician groups, and I hate to say just physician groups because it's mostly the contract management groups that aren't paying you your worth anyway, are arguing to get paid more, of course. So you can argue that the independent groups would benefit from getting paid more too, but it's more necessary to tend to the high overhead from a corporate group that's trying to make money for its investors and its debt. So that's where there's arguments and litigation right now. As for otherwise, it's been implemented. So theoretically, if you're going to an ER, you can't get a balance bill if you're insured. So that should be protecting consumers in that way. It doesn't apply to air ambulances. So that's a big just miss in that. So there's a lot of push with like HCA, big hospitals, that they'll gut all of the hospitals in a rural area and then say, well, we got to get you on an air ambulance, and then you come to our main hospital. So patients are going to still get hit with that. There's a couple of loopholes that we haven't seen if they're going to be exploited. And I believe it only, for example, only applies to actual emergency care. And so who's the arbiter of what you call emergency care? When you go to an emergency department, United Health has tried to say, well, we're going to retrospectively say that chest pain you went for emergency and to the department because you thought you were having a heart attack actually ended up being reflux, and so therefore we're not going to pay for it because it wasn't an emergency, which intuitively doesn't make sense there, right? Hopefully that gives a little bit perspective.
Yeah, that's kind of where I was going with it. And it doesn't cover things like your pharmacy in the ER. It doesn't, because that's not necessarily covered under what the ER physician is doing. It's covered under pharmacy, and there's all these little loopholes that don't necessarily it's going to help in some ways, but it's not necessarily going to be the best solution that it could have been. So going back on private equity, a lot of this has hurt rural communities more than we could imagine. How do you, because there are more physicians that are employees than employers, and that's hurt our rural communities more than anything. Do you see a way out of that? Like, what can we do?
Yeah, no, I think I agree with you in a number of ways. First of all, as we mentioned, there's EMTALA, that's sort of federal mandated, but there's no funding of this. Rural hospitals have some access sometimes to critical access funding and some state funding to go a little bit get a little bit better off. But right now, we actually, I alluded to this, with Envision Healthcare being on the skids. That's one of the largest ones from an emergency medicine standpoint, and they are so reliant on surprise billing that their EBITDA, which is, in economic terms, basically their debt to income ratio, is really off the charts, and they're probably going to default and go bankrupt. And what that in and of itself sounds great. Well, hopefully they just disappear. But the maneuvering that they tend to do is companies like this tend to do is actually take the bad part of the company, meaning the parts that aren't actually producing revenue, and then separate that off from the good ones, and then bankrupt the bad one. So what that might end up doing is any rural departments that they staff, they may isolate out and shield into a horrible one that has no assets and doesn't have any money, and then austerity measures there, so they cut down to not even having a physician. They've actually been pitching this to hospitals, which is don't staff a physician at all, staff a PA, and then have a offsite telemedicine emergency physician. And I can only imagine watching on a video camera as a patient's airway isn't taken and they die. And I say, well, move it a little like that. You can't do that, right? Yeah. So that's immensely scary to me. So we are looking through, we're actually are appealing to the FTC in a couple of different ways, specifically with Envision, because they're right on the brink of that. Now, we talk about this in a much broader standpoint, and I think we are talking about probably some kind of pay reform. I'm not saying Medicare for all by any means. I'm saying some kind of pay reform for at least emergency departments, because how do you keep those departments open, and allow a local group to be even viable there. So if you can have a local group be viable, then I think you have an option. I don't know if we want me to address the question in the chat too.
Yeah, it says, so for people not on Zoom, the question is for the general public. Is it fair to describe the proposed federal surprise billing solution as an indirect form? This is a great question. As an indirect form of price fixing?
I think, and it is a good question. And I think that it is probably exactly the propaganda from contract management groups. A separate question there. So it's actually exactly you're reading from their playbook, which says price fixing will harm patients. Now, there's of course some truth to it. And the big arguments are that we don't want to benchmark to Medicare. Now, there's an argument that Medicare is, is well researched to say that it's giving appropriate prices, and but it's the government sort of doing that. And so we don't necessarily like that. How do you determine what fair market, what the fair market value of an emergency physician is in a completely non-transparent, non-market environment? And that's pretty difficult. So they've come up with arbitration, where you're basically making the argument of what's fair in that court every time, or at least to set the precedent in that area. So I think that's half of the story. I think that if you only describe it as price fixing, then you're probably supporting what would be outsized and unfair non-market based prices for patients as well.
The next, I get this one too. And then there's, let me get one more before we go into this one. You spoke about, and we talked about rural medicine and, cutting down emergency services. Another one, we've spoken to another physician about, Dr. Darcy Bryan, is the eliminating of OBGYN services in rural medicine. That's another one that gets cut quite frequently. A student sent me an article where increasing the scope of practice in these rural communities, they're called physician extenders. That was a new term for me. It was interesting when you were talking about, intubating as, someone in the ER, but calling them physician extenders, that's an interesting term for it, I think, when you're increasing the scope of practice in these communities. So, but I said I would share that from one of the students. Okay. I have one more question for you, and then this question here. One is about, and you and I spoke about this a couple of weeks ago, residencies in the emergency medicine track. There's a lot open. Why do you think, you referenced a lot of reasons that this could be, but can we talk about that? When there are so many medical students, very qualified medical students still looking that didn't match, but yet there's a number of emergency medicine residencies open. Why do you think they don't want it?
Why do you think they don't want to go to those residencies? Yeah. So this is in the match. We saw the largest drop in residencies or residency applications this year compared to any other specialty. Now, we might be more in line with like years ago, so we don't know if that's a blip on the radar, but we definitely had I think it was a 15-fold increase in unfilled spots, meaning unmatched after the main match. And it was pretty striking. And we see that as a bit of a canary in the coal mine to say people don't want to go on emergency medicine, even though they're desperate to get slots, desperate to get any kind of residency because there are so many medical students in unmatched. So we have a pretty unique situation. Now, there was a report that came out that said we're going to have an excess of emergency physicians. So I think that got out into the medical student community that you might not have a job. And there's some paranoia that says stay the heck away from emergency medicine if you liked it, right? Now, but we dig a little bit deeper into that, and we see that the majority of these residency programs were actually started by HCA, Hospital Corporation of America, which gloats that it's the largest provider of of graduate medical education in the country, and that's in partnership with Team Health or Envision. And these are the groups that are sort of teaching metric-based emergency medicine. The orders are already in before you see the patient from a nurse at triage, and there are a bunch of orders that you often don't need, which creates more reimbursement for the hospital, and then often missing the ones that you do need, so it doesn't actually help move things along any faster. These are opening up in a large degree. We're feeling that, of course, they're likely to be lower quality residencies and contributing to the oversupply. So all of this ends up being sort of like corporately based. And, the belief is, you can't really prove it on the smoking gun to say it, but they want to create a labor monopsony. If you can hyper concentrate a bunch of physicians in one area of the country where your facilities are, then you control that market and you can pay lower amounts to them. So that's our perspective on.
Yep, that's great. Okay, the final question, because we're butting up against the time. Going back to Blackstone Equity, aren't they a Chinese Communist Party owned company? That's a great way to, what a way to end, huh?
Yeah, very specific. So I haven't heard. So actually, there's BlackRock and there's Blackstone, and they have a common background. Blackstone is the one that owns this, and some of the basics of it is basically two outsized investors. Stephen Schwartz is the owner. Schwartzman is the owner of Blackstone, or the CEO, excuse me. And then I forget Benioff. No, different guy. I forget who the owner is or CEO of BlackRock. BlackRock, you'll see it on a lot of like conservative sites, along with George Soros, I think. And so for every reason, Blackstone doesn't get as much time on that. Blackstone's actually now publicly owned in America. So it's a publicly traded private equity company, which is a little bit of a funny combination. So to my knowledge, there isn't any Chinese Communist Party ownership there. Maybe that's another equity group that I'm not familiar with. But I will say that they end up acting like the Chinese Communist Party in many cases, or at least when you're working for them or underneath their own companies.
Well, with that, I want to thank everyone. I want to thank you, first of all. I want to thank you for what you do. It is so important, first of all, that you are advocating for your profession. You're advocating for emergency medicine, you're advocating for healthcare, and you're showing what grassroots advocacy can do. We need you and so many more like you, and I am thrilled that I had the chance to meet you. If you are interested in what Dr. Lee is doing, please go to Take Medicine Back and look and contact him. We have all of his contact information, so we will send that out. We also will, this is being recorded, we will put it up on our YouTube site. I recommend and I hope that you are all on our newsletter list, and you can go to benjaminrushinstitute.org and just click on newsletter, sign up, and you can be informed of all of our future, all of our future virtual event series, and get all the information about what BRI is doing, including our new legislative outlook section of our newsletter. Our legislative director is putting out what's going on in the states, which is very interesting and informative. So if you have other reasons, other ways to be advocates for your profession or your future profession, you know how to be involved. So Dr. Mitch Lee, thank you so much. Everyone who joined us, thank you so much. And I look forward to the next one. Have a great day, everyone.